Good morning, good afternoon, good evening, and welcome to our CND side event on disparities in access to internationally controlled essential medicines in the Caribbean. I'm Dr. Catherine Pettis, Senior Advocacy and Partnerships Director for the International Association for Hospice and Palliative Care, which is a non-governmental organization in consultation with the UN Economic and Social Council, and our vision is a world free from health-related suffering. For our attendees all over the world, please introduce yourselves and your organizations in the chat and put your questions in the Q&A, and we'll try to get to them if there's time. And if not, we'll respond to them by email. So it's now my honor to introduce my friend, colleague, and IHPC board member, Dr. Dingle Spence. Dr. Dingle Spence is a Jamaican physician with training in clinical oncology and palliative medicine. She's co-founder of the Jamaica Cancer Care and Research Institute and co-founder and president-elect of the Caribbean Palliative Care Association. And I'll be back in a bit to introduce some of the other speakers, but in the meantime, Dingle, the floor is yours.
Good morning, good afternoon, good evening to everybody, and thank you so much for joining us. It's my pleasure now to introduce Her Excellency, the Ambassador Cheryl K. Spencer, our permanent Jamaican representative to the United Nations. Ambassador Spencer, the floor is yours. Thank you.
Thank you very much, Dr. Dingle Spence. Thank you also to Dr. Catherine Pettis, our chair, Sir George Allain, Director Emeritus of the Pan American Health Organization, Dr. Dingle Spence, President-elect, Caribbean Palliative Care Association, Dr. Catherine Pettis, Senior Advocacy and Partnerships Director, International Association for Hospice and Palliative Care, representatives of the UNODC, colleagues from the Ministry of Health and Wellness of Jamaica, excellencies, distinguished ladies and gentlemen. It is indeed a pleasure for me to deliver opening remarks on behalf of the government of Jamaica at this very important side event. One notes in the WHO literature a simple sentence that says palliative care is not passive care. It therefore must be available at all levels of care, be it at the life-limiting, life-threatening, or life-prolonging level, thus improving the quality of life of persons. At the center of this is access to essential medicines, such as morphine, which is recognized as the gold standard for pain relief, noting that the control of pain is a priority for treatment in palliative care. That is why this discussion today, to examine and highlight the disparities in access and availability of those essential medicines in the Caribbean region, is so critically important. According to WHO statistics, an estimated 40 million people are in need of palliative care, 78% of whom live in low and middle income countries, and within that context, a very high percentage of children. Jamaica remains concerned that the availability of internationally controlled substances for medical and scientific purposes remain from low to non-existent in many parts of the world, the Caribbean included. Disparities also exist even among the latter countries themselves. The COVID-19 pandemic has further exacerbated the challenges to access and availability of essential medicines, including for pain and palliative care, through disruption in the medicines supply chain. Needless to say that access and availability of medicines are important to achieving the health outcomes under the Agenda 2030 for Sustainable Development, in particular Goal 3, as well as the right to health. It is recognized, Chair, that there are several barriers to equitable access, including inter alia, lack of awareness among policymakers and health professionals on palliative care, culture and social considerations, misconceptions regarding palliative care, and linkages to increased substance abuse. This year, 2022, marks an important milestone, the 45th anniversary of the development of the WHO model list of essential medicines. Jamaica is therefore delighted at being a member of the Commission during this period. We're also pleased to have witnessed the official launch of the joint call for action on scaling up the implementation of international drug policy commitments on improving availability of and access to controlled substances for medical and scientific purposes, which was held on the opening day of this session of the CND. Further, there is a critical need for a stronger and renewed thrust to addressing barriers to access in accordance with inter alia, the 2016 UNGAS outcome document. In 2021, Jamaica was pleased to have led on a resolution in the WHO on strengthening nursing and midwifery, which reaffirmed the importance of investing in the health workforce. Greater investments in education and training of health professionals, including embedding palliative care in core curricula, will be a positive step in the right direction. And in that connection, we are now embarking on a primary healthcare reform agenda in Jamaica that includes the definition and implementation of palliative care services in primary care centers. The build out of this area of care indicates our appreciation of the need. Further to this, the Health and Wellness Ministry will support the launch of a diploma course in palliative care at the University of the West Indies to ensure a cadre of trained health and care workers. We also recognize that as small island developing states, we grapple with stark realities of capacity constraints, especially human and financial constraints. It is therefore essential that this issue be kept at the forefront of the political agenda, and that countries in the region work together in collaboration with partners such as PAHO, including through the PAHO Strategic Fund for Essential Medicines, with a view to increasing access. Please rest assured of the Government of Jamaica's commitments to continuing to emphasize the importance of the implementation of our joint commitment based on the principle of common and shared responsibility, which in this instance is to increase access and availability of medicines for the most vulnerable. In closing, I wish to thank the panelists, reflecting the keen interest of civil society. We thank the UNODC, and along with the commitment to addressing this important issue. And of course, sincerely to Dr. Spence for her efforts and her initiative in seeking to highlight this concern. We owe it to millions of persons in need of palliative care to find and explore avenues to provide much needed medicines to reduce pain and suffering. Thank you, moderator.
Thank you, Your Excellency. It's a great honor to have you with us today. And now it's my honor to introduce Dr. Karen Cox, family physician working in palliative care in Trinidad and Tobago. She is a member of Carapalca and the Palliative Care Society of Trinidad and Tobago. Dr. Karen, the floor is yours.
Thank you, Catherine, Your Excellency, Ambassador Cheryl Spencer, Professor Sir George Allain, and colleagues. It's an honor to be here on this platform today representing the Caribbean Palliative Care Association. Next slide. So who are we? Carapalca is a regional palliative care association, and we represent the people of the Caribbean community. And our mandate is to ensure that the people of our region experiencing health-related suffering have a voice. So we exist to promote palliative care development, education, and to advocate for palliative care on national, regional, and global platforms like this. Next slide. So the WHO's public health strategy for palliative care acknowledges that medicine availability is a key component. And our advocacy today centers around that: access to medicine, specifically access to controlled essential medicines. Next slide. And what do we mean by essential medicines? Well, these are medicines that satisfy the priority health needs of a population. And for our patients dying of cancer and other illnesses, the priority need is pain relief and relief of suffering. The WHO model list identifies 3 key players, 3 drugs: codeine, fentanyl patches, and morphine, as the main essential opioids. And we're focusing particularly on morphine today, as it's the global strong opioid of choice for cancer pain relief. Next slide. So the unavailability or inaccessibility of essential medicines results in health-related suffering. And this is what suffering looks like or can sound like. And it means the patient experiencing unrelenting distress suffers. There's suffering on the side of the relative who bears witness to this. And often the the health professional, if he has no access to drugs to relieve this distress, also suffers. Next slide. So recognizing the importance of these essential drugs in our region, we did a quick survey of practitioners on the ground in 6 Caribbean territories, asking what's out there, what do you have access to? And we found that there were several worrying findings. 3 of the 6 countries had no access to immediate release morphine. And to highlight this, this is quick acting morphine. This is the gold standard for severe acute pain. So this is an untenable situation. Many of the countries reported frequent stockouts of various formulations, restricted formulations, so really difficult to titrate doses when you only have one strength, scarce alternatives, often at a cost. And if you're a patient in the community, far from a central dispensing hospital, challenge in accessing these medicines, particularly in an emergency or after hours. Next slide. And there were quite wide disparities among the countries we looked at. Jamaica seemed to fare perhaps the best, and Dr. Spence will speak to that later. At the other end of the spectrum, we had Guyana with really poor formulary availability. If you have only injectable morphine and slow release morphine, what that can look like is either you have to take yourself to a hospital as a patient in pain to receive an injection, or the difference between slow release and quick acting is you wait 90 minutes for pain relief as opposed to 15 minutes. And that is unacceptable when oral morphine is quick and effective and cheap. Some countries had more stringent regulations in terms of who could prescribe and where the drugs are available. And then the repeated issue of stockouts, Belize, Trinidad and Tobago. Next slide. There were multiple barriers. These are some that my colleagues identified. And a main one was the feeling that palliative care did not feature on the government agenda. It's not a priority. 5 of the 6 countries had no national palliative care policy. And so political will to ensure the necessary frameworks were lacking. The frequent stockouts make us think that there's inaccurate forecasting of our estimates. And we recognize that these are drugs of abuse and diversion potential. But if regulations are so stringent that a patient in pain cannot get relief, then something needs to change. Morphine is an old and cheap drug, and so the low profit margins for private pharma make it unattractive. And that's another challenge. And the last 2 really speak to the need for ongoing education. Health professionals receive very little training around prescribing and managing opioids, and stigma persists not only among lay persons, but also among health professionals and colleagues. So a lot of work is needed to change this. Next slide. So in summary, there's still really poor access in some areas of the Caribbean. And if we accept that pain relief is a basic human right, then I think we have a responsibility, a moral responsibility to change the situation. Thank you. I would like to hand you over now to my colleague, Nurse Bibi Salim. Bibi is a palliative care nurse trained at St. Christopher's Hospice in the UK, and she is currently the lead palliative care nurse at Beacon Foundation in Guyana. Bibi?
Good greetings from Guyana, all protocols observed. I will attempt to shed some light on the availability and accessibility of the opioids in Guyana. There, I would like to give a little background of our country. We are the only English-speaking country in the Caribbean, in South America, sorry, and as such, we became one of the founding members of the Caribbean community. Guyana is large, it's 83,000 square miles, and it is divided into 10 administrative regions. Now, the Beacon Foundation, which is a non-governmental charitable organization that offers domiciliary palliative care to cancer patients in Guyana. We are only able to service 5 of these administrative regions. And this is all due to the fact that the other areas are kind of like very difficult to access. So straight away, you can see that there is the accessibility to these areas would make it difficult for these patients to have the kind of treatment they really need. The opioid that are available on the Guyana drug formulary are the tablets morphine 30 milligrams. That is the slow release. Also the 10 milligrams. We have tramadol tabs, the codeine and liquid morphine, which is only available in the private hospitals. We have injection petadine and tabs petadine, injection morphine 10 and 15, and the injection fentanyl, which is also only available at the major hospital, that is the Georgetown Hospital. The Beacon Foundation, which gets all of its opioids from the government, it can only access the tabs morphine whenever it's available, which we will show a little later has been quite out of stock quite a few times. The tabs morphine, cocodamol, codeine, tramadol, morphine injection, and petadine injection. Those are what we have to work with. So okay, the drugs that are issued to the Beacon Foundation, this will give you an indication between 2018 and 2021, what we had to deal with. We would have made requisition 139 times. Of 80 of those, which is 58% of the times we would have ordered. We did not, we only received the opioids. Of the 80 times that we received, 16 or 20% of those times, the request amount was not received. And 50% of the times we were stocked out. So straight away, you can see our patients are going to go through a lot of suffering because they can't access the most important medication. Now, the barriers to all of this is the quantification number is not accurate to usage, which means that the amount that is being ordered by the materials management unit of the Ministry of Health is not accurate to the amount of medication that is actually being used in the system, not only for palliative care, but for all other services. And there is also the overutilization of opioid in the departments such as surgery, especially the post-op areas, where most of the surgeons now prefer to use the morphine rather than using the other painkillers that can actually work and leave the opioids for patients who have cancer. So there is also the inaccessibility to remote areas. If you would have looked at the map of Guyana, I'm going to go back to the first slide, you will see that we have where the administrative regions are. Like region 1, that's right at the tip of Guyana. Those are mountainous area. Region 7, region 8, those areas are very difficult for us to service. We service region 2, 3, 4, 5, 6, and 10, which is easily accessible to us because we can drive and get there. But the other areas, you either go by boat or you have to go by plane, which because we are an NGO.
1 minute remaining.
Sorry, which means it's impossible for us to access those areas. Okay, all right. The unavailability at the primary health care facilities as the health centers and the health posts. And Beacon being an NGO, we are not included in the Ministry of Health budget. So I would like to acknowledge Ms. Hermanetta Andrews, who's an RN and my colleague at the Beacon Foundation, and Mr. Atkins of the Ministry of Public Health Pharmacy Division. Thank you. I would like to now introduce Ms. Verna Edwards, who is the Scientific Officer at the Ministry of Public Health and Wellness in Jamaica. Thank you.
Greetings, everyone. I will be presenting on challenges of opioid availability in Jamaica. Next slide. So my objectives include introduction to the island of Jamaica, barriers to access and availability of opioids, our legislation and regulatory framework, and I will conclude. Next slide. So Jamaica is an English-speaking island in the Caribbean. We have a population of approximately 3 million people, and we have 4 health regions with 24 public sector hospitals and 1 university hospital. Next slide. So what is unique about Jamaica? In June 2008, 2 representatives from Jamaica, Dr. Dinga Spence, Hope Institute Hospital, and Verna Edwards from the Ministry of Health and Wellness were awarded an International Pain Policy Fellowship by the University of Wisconsin. The focus of the fellowship was to improve availability and accessibility of opioids in Jamaica. Next slide. So prior to starting the fellowship, we did a survey and we identified several barriers to access and availability of opioids. So some of the barriers we identified were availability of stock. Are these stocked in the cupboard? Appropriate use of opioids for the management of cancer pain. Should the drug be used as needed, or should we be prescribing the drug that the patient take it around the clock? Cultural misperception about the use of opioids, that these drugs were dangerous. Use of opioids relating to death or dying. And we saw where persons would be afraid of actually taking the drug, just denying themselves the care they need to relieve the pain. We also saw the need for training of healthcare providers. To the right, you will see I've listed all the opioids we have in Jamaica. We have codeine, injection and syrup. We have morphine in all presentations. We have powder, tablets, immediate release and long acting. We have the morphine injection. We have fentanyl patch, and we also have fentanyl injection, which has been very useful in surgery, along with palliative care. We have petidine, which we are using less of, and we have oxycodone, which was actually added during our fellowship. Next slide. So you can see from this slide that since we completed the fellowship in 2012, we have been able to maintain good stock levels of morphine in Jamaica. However, during the COVID experience over the last 2 years, we have been having challenges with our immediate release tablets. So what we have been doing is we have been using the powder to make the syrup, and this is made in the public sector hospitals where we make the syrup so that the doctors can prescribe the immediate release. Next slide. So I am a regulator in the Ministry of Health and Wellness, and I was in the position for over 10 years. So the Ministry of Health and Wellness Standards and Regulation Division is responsible for regulating the importation, storage, and distribution of controlled substances, including opioids, through various legislations. So we have the Food and Drug Act and regulations, and it does speak to control drugs. And we use, under the act, we register our drugs. We have the Dangerous Drug Act and regulations. We have several legislations. So the framework speaks to authorization of our health professionals, doctors and pharmacists. We have permits, we have our cupboards, our prescriptions, we fill on originals only, and we do our submission of annual estimates. Next slide. So in concluding, what has the fellowship done for Jamaica? We have been able to improve the knowledge and awareness of and use of opioids to relieve pain and suffering of our people in Jamaica, strengthening of the legislations and health system to improve access and availability of opioids. And we propose the development of a regional pain management policy. Next slide. So in closing, thank you for listening. And we leave with the quote, somewhere along the way, we must learn that there's nothing greater than to do something for others. Thank you. We will now move to introduce our patient. We will now show a video of a patient experience. Mr. St. Lawrence is a woman in her early 50s and works as a secretary in a government agency. In late 2021, she was diagnosed with pancreatic cancer and is currently being treated at the Hope Institute Hospital in Jamaica. We now present this video. Thank you.
Yes, I was treated. I'm now treated at the Hope Institution. Oh my God, I can't tell you. It was terrible. It was terrible. The pain was hard. I couldn't stand. I couldn't sit. I couldn't lie down. It was terrible. It was terrible. What hope does is give me something, the painkiller to ease the pain. And the pain is a morphine. I get a little tablet and I get the patch, the pain patch, but it doesn't effective like the morphine. The morphine, both the liquid and the tablet. The morphine, it take it in space of less than 5 minutes. You get an effect from it. You understand? You don't feel that pain anymore. You understand? So I rather having the morphine than the patch. You understand? I still use the patch, but the morphine is more effective to me. Well, I can do anything. I can sit up. When the pain starts, all I have to do is just take the morphine. When the pain starts, I just take the morphine and just lie down, and that's it. Taking the morphine, it just ease. It just gives me a relief. It just gives me a relief. Yes, this is the patch. But I just wear it because I get it and I don't know if it helps. Because having the patch on, it pains just the same. But taking the morphine, as I would say, just the morphine, it's excellent.
Could we change the slides now to the next talk? So I'm Dingle Spence, and I've been introduced already, and I want to continue to talk about the disparities in access to opioids and offer some potential solutions to the situation that we're facing. Next slide. So my objectives are to give you another brief introduction to the disparities in opioid access in the region, and then to continue to talk about an initiative that has worked in Jamaica, and then to offer 2 potential solutions to help move member states forward towards concrete action. Next slide, please. So here we are in the Caribbean again. We've seen this map a couple times today. So we have a large population, 44 million, 6 million English-speaking people. And as you can see, we do have the Caribbean community, otherwise known as CARICOM, the members of which you can see on the right of the slide. Next slide, please. So this graph is really why we're here today. This is looking at the morphine consumption in the Pan American Health region. That's the region of the Americas, including the Caribbean. And that green line that you can see is what we call the global mean. So the global mean is 4.6 milligrams per person of morphine consumption. And if you look carefully, you will see, in fact, only one country in the CARICOM region actually touches the global mean. Everybody else is very, very, very far below, including countries in South America, Central America, and certainly pretty much all of us in the Caribbean region. So that is really a desperate situation, and it means that there's an awful lot of people suffering out there in pain and distress. Next slide, please. So I wanted to share again and continue on from my colleague, Mrs. Edwards' talk about how we managed to improve access and availability of morphine in Jamaica. And just a 2-second story, I came home to Jamaica here, and in end of 2002, and by the beginning of 2003, I had used all of the morphine in Jamaica by prescribing it correctly as I had been trained. I then met Mrs. Edwards at the Ministry of Health, and we made an emergency order to the International Narcotics Control Board, and we were able to bring more medicine into the country. We then were very fortunate to embark on the fellowship, as you have heard, and we were so proud to be able to increase medicine access in our country. Next slide, please. So how did we do that? Well, you have heard from Werner about the regulatory framework and the policies that are required to govern the distribution and accessibility of these medicines. There's, of course, as has been mentioned before, the medicine availability and education piece that cannot be separated. So we actually embarked on a very intensive education campaign. We went to all 24 public hospitals in the island. We interviewed people. We gave talks to a wide range of healthcare practitioners. And partly also what was successful is that we were able to bring to the table a wide range of people. So policymakers, pharmacists, practitioners, and sometimes, in fact, users as well, to do education and training. We were able to develop a chart that was put on hospital ward walls so that people could have a quick reference. So education is, we can't do without it, obviously. And then we were very proud also to be able to increase the availability of medicines. We found a cheaper bulk source of powder. As you heard, that powder is used and compounded into the liquid on the bench, but not all the public pharmacies can do that. So we were then also able to bring in supplies of immediate release morphine tablets, both in public and private sectors, so that there were no difficulties in having to compound the powder on the bench into the syrup. And although we still have issues with distribution in our more rural sectors, in the central parts, we do now have access to these medicines, although, as we have said, COVID has made it difficult. Next slide, in recent years. Next slide, please. So what can we do as a region to enable change? And again, we've seen this little diagram on the right, but I want to speak to the implementation side. How do we actually do it on the ground? So we already have regional groups. We have CARICOM, we have CARPHA, the Caribbean Public Health Agency. We have CARIPALCA that you've heard about today. And we, of course, have our regional academic institution that is on many of our islands, the University of the West Indies. Next slide, please. So I'm going to offer a couple of solutions. I think the model of the Pain Policy Fellowship that myself and Werner Edwards went through, and you can have seen from the graph the changes we were able to put in place, this is an excellent model. And I think that we can translate our own equivalent into the Caribbean. We have many small island developing nations, and we're likely to need an individual approach to help support each island in its own efforts. I think one of the most important things is to enable real change on the ground, and this means bringing people together around the table. COVID has taught us that we can do an awful lot in the virtual arena. What we need to do is help individual countries formulate their action plans and support them as they move through in the way that we did here. And I have no doubt that that will bring success. Next slide, please. And then, of course, we have the Pan American Health Organization Strategic Fund, which is a regional mechanism for pooled procurement of essential medicines. And on the left, you can see what is offered. And as has been said already, morphine is inexpensive, it is generic. And what also has been mentioned is there's very little interest from private sector to be bringing these things into countries. So is there a way that we can work together in the region using the connections we already have, building on those? And I think one of the things that the Strategic Fund offers is the 5 pillars that you see there: technical cooperation, which is what we're talking about, pooled procurement, building capacity, quality assurance of the medicines that are being dispensed and provided. And there are innovative financing mechanisms available as well. So to me, if we have a fellowship policy approach which brings people to the table who are actual end users, people who are working on the ground, and bring the region together in a way that we can access these things. We shouldn't just see them on a slide. This is real. We can do this. We already access HPV vaccinations. We access antiretrovirals in this way. So why can we not access these essential medicines that we need for managing pain and suffering? Next slide, please. I'm just going to finish with showing you these pictures. The Caribbean Palliative Care Association came into being in 2016, but we started with a very important meeting in Jamaica in 2015. And I want to just introduce the people on the left-hand slide, as this will segue into the closing remarks. So there on the right of that picture is Dr. Jim Cleary, who is in fact the mentor to myself and Werner Edwards in the Pain Policy Fellowship, and I believe is on the call with us today. Thank you, Jim, for all the support you have given us. Next to him is Dr. Fenton Ferguson, who was the Minister of Health at the time and was very supportive of our initiative. Then we have Liliana de Lima, the Executive Director of the International Association for Hospice and Palliative Care, who has been a friend and colleague and fervent supporter of all we do globally and also in particular in the region. And then on her, to her right is Professor Sir George Lane, who I would now like to formally introduce to give the closing remarks. Prof, what can I say? Professor is actually an old family friend. He probably knew me when I was in utero. He is the Director Emeritus of PAHO. He's a Barbadian national. He's a graduate of the University of the West Indies. And if I was to go through his CV, that would take up the rest of the webinar. So I'm going to now hand over to Prof. Sir George Lane to give us the closing remarks. Thank you.
Thank you very much, Dingle. That's very generous of you. And let me say hello to Jim, since I can't see him in person. Let me greet the ambassador, Dr. Pettis, Dr. Spence, colleagues. Thank you very much for having me along with you. As you say, as Dingle said, 2015 is a long way. And in some ways, it has been a productive ride. I want to congratulate Dr. Spence, actually, for being one of the leading lights in this area and for galvanizing people to act in this area. We have heard the ambassador give a tour de force and setting out the international problems that attend lack of appropriate opioid use in the Caribbean, in the world as a whole, and in the Caribbean. She's dealt with the political aspect of it. She's dealt with the technical aspect of it. And we heard from participants about the many problems that occurred. We saw a very touching video from a patient attesting to the value of pain relief. And we've heard a repetition of the barriers that occurred. And then when Dingle first asked me to participate, and also reflecting on what I've heard this morning, I reflected on the nature and the possible solution to the problem. and Dingle has already alluded to some of the solutions to the problem. I think one of the first things that struck me in 2015 and through the last 7 years has been accentuated is the whole idea of the inequity. Even in the Caribbean, there is gross inequity in the availability of pain-killing, pain-relieving or pain-killing drugs. And what I've come to the conclusion, one of the conclusions which I've come is that the availability of these drugs and the attention to relieving suffering, health-related suffering, this should be one of the indicators of the efficient functioning of any health system. And I think when we speak about the strength of health systems, we have to introduce this as one of the indicators for how a health system really functions. If a health system functions to the benefit of the population it serves, then we should see this as one of the indicators of the efficiency and effectiveness of that system. It's not only inequity in other areas, but inequity in this particular area, I think, should be one of the indicators of the efficiency of a good health system. One of the other areas that has worried me, and I've heard echoes of this elsewhere, the conflation of the problem in the Caribbean with unavailability of opioids with the problem in the United States with the overuse of opioids. I have found sometimes in discussion that these two things tend to get conflated, and we must resist that as vigorously as we can. The Caribbean problem, there may be people in a Caribbean who use opioids unnecessarily, but that is not the problem. The problem is the lack of availability and the inequity in the utilization of these drugs. One of the other areas that has concerned me and is concerned over the years and more increasingly now is this view in the Caribbean in various places that there is some value in redemptive suffering. There is some value to suffering, that people should suffer. It is a mark of character. It is a mark of some deeper spiritual value, as it were, is that you should suffer. And in the final analysis, you will relieve of your suffering in the hereafter. This idea of redemptive suffering, and somehow we have to get it to various places. And I speak not only of the technical educational institutions, but also in the religious institutions, that there is no value in redemptive suffering. So there is no need for people to suffer at various times in their lives. The other thing that has always struck me is almost the equation of palliative care with terminal care. There are other places in the care spectrum along which you will need to have pain relief. So the idea that is only at the end of life is only in terminal illness that you need attention to care. The other thing that has struck me is the fear among the medical profession, some fear of overuse, some fear that patients may become addicted to drugs. You have an 80-year-old gentleman or 80-year-old lady with pancreatic cancer, and you fear that that person might become addicted to drug, so therefore that person continues to suffer. Now, what can be done? I think this morning's seminar has shed a ray of light on the possibilities of addressing this issue. What is it shown that there is a dedicated band, we've only seen a small numbers of them, a dedicated band of individuals who are which is committed, the individuals who are committed to addressing this problem. And I heard in the voice of the ambassador the conviction that at her level, there is something that she can do also to address this problem. So in the light of this seeking this committed band of individuals, let me argue for the search for what are called political entrepreneurs, what are called champions. It would be good in the presentation of this to the persons who have power to change the ideation of those in power. It would be good to seek out and have some champions commit to putting forward this cause in various locations. So is there some light? I say yes, there's light in that there is this committed group of people. There's some light in that there has been progress where there has been concerted and effective action. Has there been some progress? Yes, in the sense that there are more people at various levels who are aware of the problem, but there's still a lot to be done. But I take comfort from the words of Margaret Mead, who said, never doubt that a small group of individuals cannot change the world. Indeed, as she went on to say, it is the only thing that ever has changed the world, this concerted action of a small group of committed individuals. So once again, congratulations for pointing out the problem. Congratulations for showing that there are solutions to the problem, and congratulations for the commitment of this small group of people to advancing the cause of health for all. Thank you very much, Dingle.
Thank you, Sir George, for joining us today. We really appreciate it. Over to you, Catherine.
Oh, thank you, Dingle. We have 4 minutes left. If anyone has a burning question, they could put up their hand and ask it live on the air. If they don't, then I could close this out, or I could ask a quick question of you, Dingle, just to put you on the spot. That one of the big concerns about CND at CND, and I'm there now, so I keep hearing it, is the issue of diversion and misuse. And so how does Jamaica and the way that you've been able to increase access, how do you manage to, what would you say about preventing diversion and misuse?
So Werner and I were speaking about this last night, and as you could have seen from the curves, we obviously do have more morphine in the system now. But I think we actually have very little diversion and abuse in Jamaica, and there's I think we have a very tight regulatory framework thanks to the Standards and Regulations Division in our ministry, and those have been strengthened over the years. So as Werner pointed out, only original prescriptions can be filled. I believe there is now a network between the pharmacies that dispense controlled medicines, that they're aware that when a prescription is filled, so that people cannot go to multiple pharmacies with multiple prescriptions. We're also very fortunate that culturally it's not really an issue. We have other drug issues, but addiction to painkillers or diversion of painkillers in our particular cultural setting, fortunately, is not a huge issue. But I will just say again, the regulatory framework in the country is what keeps things safe. Thank you.
Thank you, Dingle. So you could recommend that as a model, for instance, to other countries.
Absolutely, and I think
yeah.
And I think this is exactly what we're talking about with the fellowship that helps us look at what we have on the ground and look towards changing things if necessary. Yeah,
Excellent.
Thanks for the question.
Well, we're at our hour, and thanks to the Walther Center for hosting this, for the platform, to the Vienna NGO Committee on Drugs for co-hosting, and the UN Office of Drugs and Crime, and to Kara Polka and all the wonderful speakers, to Your Excellency Ambassador Spencer, and to everybody. So thank you. And we've got a lot of work to do, but we've been talking about that at CND and ongoing steps to make this all happen. So have a wonderful rest of the day, if you have a rest of the day, and good weekend to everybody.
Thank you.
Bye.
Thank you, everyone. Really appreciate your company.
There were a few questions
Bye-bye.
that came in at
Thank
the
you
end.
so much.
We'll be sure to get that to everyone. we'll be sure to
Thank
circulate
you.
and respond.
Okay, so we'll answer those on email then, right? Sorry, I didn't see any
Correct.
questions. Okay,
No, they came in literally just at the end.
okay. All right,
Okay,
bye, everyone.
all right. Goodbye,
Thank you
everybody, and
all.
thank you for being
Excellent
here.
session.
Bye
Thank you
now.
so much.
Thank
Bye-bye.
you.
Bye.